hypovolemic shock. Now, are their serum sodium levels normal? Are they high or are they low? If water and sodium are lost in equal amount, is the serum, if I draw sodium levels, high, low, normal. Don't overthink this. It's in the chart. I said they're lost in equal amounts. So it really doesn't shift. So we got high, low, or normal. Lourdes is high. They're actually normal because the balance is still there. The water and the sodium are still balanced within the body. We're just losing a lot of it. Okay, so it's isotonic. When you see the word isotonic, that means serum sodium levels are normal. Okay, they're normal. So we're going to go look at hypotonic dehydration, where electrolyte loss is greater than the water loss. All right. Where the water moves extracellularly to intracellularly. All right. So our clinical manifestations with the degrees of dehydration will be more severe with a smaller fluid loss because it shifted from extracellular to intracellular. Can they go into shock? It's just a yes or no. Can they go into shock? If smaller losses of fluid causes more problems faster, can they go into shock? I know it's early. yes, they can go into shock much faster. Okay, so what do you think their serum sodium levels will be? We already got normal, so that's out. There's only three. There's high, low, normal. And normal is isotonic. So is it low sodium or high sodium levels? Because only the water moved. Sodium did not move. Right. So they will have low sodium. They can go into shock. And their serum sodium levels are low. They're less than 130. Okay. And when we have hyponatremia, they can cause seizures. They can have severe problems, mostly seizures, and coma death. We have to fix it. So to fix this, we have to give a 3% saline solution, which is pretty bad. I've only ever had to do this a couple of times as a nurse, where we had a child with a brain tumor and suddenly they went into shock and their serum sodium levels, because they had cerebral salt wasting disease, I had to give 3% like 3 times before we had the ability to take them to the ICU. ICU needed a room. We needed a room in ICU, basically. And we were waiting, but while we were waiting for this room in ICU, I had to start these 3% saline solutions. And we gave a dose of 3% saline, and the sodium went from 125 to 127. And like, we got to give another dose of 3% saline. And pharmacy had to walk up each one. It was a lot. And finally, they just gave me a bag of the stuff. And they're like, well, just get it off this bag. Usually they give you specific, like, here's a piece of the bag, like, here's 100 milliliters, here's 50 milliliters. No, they just ended up, the second time they came up, they just gave me the whole bag. So the physician's like, this is too much for us to wait for a 3% saline. Just give us a 3% saline 500 ml bag, and we'll just pull off what we need. And that's a lot of saline, let me tell you. I mean, when you're talking about bolusing, that's 0.9 normal saline, just 0.9. When you're talking about giving them maintenance fluids, that's D5, dextrose 5% in D545, so it's 0.45 normal saline, or 0.9 normal saline, or 0.33 normal saline. 3% saline solutions are very dangerous medications. So you have to be very careful using 3% saline solutions, let me tell you. So be nervous. If you are giving a 3% saline solution one day, be nervous. This patient is losing sodium somewhere, and badly. All right. So what is a type of disease that can cause a hypotonic dehydration in infants or children? Well, I said cerebral salt wasting because they're losing salt, but there's another way that can happen where they have too much water. We're like, but we're talking about dehydration. Don't overthink this. Okay. What happens is called water intoxication. People can die from water intoxication. There was a case in the news, like, this was a long time ago, before I became a nurse. I remember this radio station was giving away PlayStations. I think it was PlayStation 2. If it was like a water drinking competition. And this lady drank 4 gallons of water. And she had a seizure. They did this contest. She had a seizure and she was sent to the hospital. Her sodium was tanking, like she was in the 110s. She died from water intoxication. So how does this happen in children? It's not because they're drinking too much water. And this is not also a plug for Gatorade. I don't like electrolyte waters in children. I don't think it's necessary. But when we're talking about diluting formula in infants to save money, they can easily go into a type of water intoxication, unfortunately. And so how do we prevent this particular problem from happening is that, number one, do babies from 0 to 1 year of age need water ever? Because it's a old wives' tale or it's a grandma thing. That they're like, oh, they're thirsty, give them some water. No, they get formula. Formula is made of water. Breast milk has water in it. They need to be having nutritious, formula or nutritious breast milk. That's what it is. They don't need water. They can get their fluids from their foods. And so that we have to be very careful when talking to parents about, are they giving water? I mean, it's not like it's a controversy. That's not what I'm saying. I'm just saying that we had to be careful and we had to remember we have to be caring enough to remember to talk to them about, you don't need water. We need water. The babies don't need water like that. You're mixing formula, you're putting water in it. It's enough water for them. We don't need extra water. You're diluting them now. So sometimes when I do see a hypotonic type dehydration in infants is because they're getting free water, or sometimes we have to ask parents, like, how are you mixing the formula? Show me how you do the formula. Tell me where you do it. And so they don't read the directions, or they're trying to make the formula stretch. And that doesn't work for the baby. It can cause a hypotonic dehydration. Okay. Moving on. Hypertonic dehydration, where the water loss is greater than the electrolyte loss. So they're losing water. but the sodium is staying, and the electrolytes are staying within the body. And the fluids are going to move intracellularly to extracellularly, and there are neural changes. What kind of neural problems are we going to have if we have increased electrolytes in the body? What kind of neuro changes can we have when we have a hypertonic dehydration? Loss of consciousness? Yep. What else? Yes, decreased loss of consciousness. What else? If they have too much sodium, what's like signs and symptoms of hypernatremia? Right? Dizziness, seizures. Do not forget about like irritability, they're mad, and hyperreflexia. It increases muscle movement. And then once we get into like seizures, it leads to coma and death. Hypertonic dehydration is also not fun. Can they go into a shock? I'm just going to tell you guys, not as likely. Not as likely, but they can have, it's going to be like a neurologic problem instead of a shock problem. Okay. They're going to have Glasgow coma scale issues other than it's not a shock issue. And this is the last one of the serum sodium levels. They'll be very high. They'll be greater than 150. And some diseases that can cause this hypertonic dehydration is like diabetes insipidus. All right. And that's hypertonic dehydration. Again, the 3 types of dehydration shouldn't be complicated. It's all about sodium here. All right, now we're talking about degrees of dehydration. And what I'm talking about, so will always be a type of isotonic dehydration, okay? The weight loss is the key. Weight is the most important determinant of total body percentage of fluid loss in younger children. Now, I'll not ever ask you to calculate this. Lucky in a day if you ever get a previous weight on it, or the parents even remember how much they weighed and what they weigh now. So usually we just go by clinical manifestations, but if you can get a weight, gold standard. All right, so typically we're talking about a 3 to 5% total body weight loss. Not easy to calculate 3 to 5% total body weight loss. You just need, I would recommend that you know that it is a 3 to 5% total body weight loss, just a percentage wise, but not about the calculation. You also need to know the clinical manifestations, which, let me tell you, these are within normal limits. They should be acting normal. They have normal mucous membranes. They have a normal fontanelle. They will have a normal pulse rate, and they will have a normal blood pressure. We, all of us in this room, have mild dehydration. In general, most people go through life with mild dehydration. Okay? And they'll be a little thirsty. Okay? They'll have a cat refill is still relatively normal. And they'll have this slight thirst. Okay, so let me tell you, you and I, everybody usually runs around with mild dehydration, and that's fine. And we'll survive this. But when they're starting to come to the ER is when we see people going into moderate dehydration. We can solve mild dehydration at home. We need a little bit more intervention when we're talking about moderate dehydration. And we're talking about a 6 to 9% total body loss in any age whatsoever. Now we're going to have more severe next level clinical manifestations. And they're going to be thirsty. Now they're going to be thirsty. Their pulse rate will start increasing. They'll start getting a little bit tachycardic. Their pressures will still be stable. They're going to have a drier mucous membranes. They're going to decrease in tears. They're going to have some increased skin turgor. They're slightly more tachypnic. Their fontanelles on the infants could be sunken, but it's only like 6 to 9%. It is not a huge loss here. Here also, diapers are going to start decreasing. Also, should have added this. Diapers start going down. This is when we see kids in the ER, but we can still solve. We don't need to start an IV yet. Prevention here, or interventions here lead down the line toward oral interventions, where we're trying to get them to drink, solve the problem, get them to be less nauseous and less vomity. Then we can get them to start drinking. And we'll talk about what we introduce to drink, because we're talking about like 0 to any age. We have specific types of drinks that we recommend. But we can solve this with oral rehydration first. If we can't solve the vomiting problem or the diarrhea problem, then we'll start an IV and we'll solve the issue there, right? That's an easy way to increase circulation, is to give them a little bolus, start some maintenance fluids. They'll feel better in an instant, probably go home that night, typically with moderate dehydrations. Boluses make a lot of people feel better, right? We've all heard of hydration therapy. Well, guess what? It stems from this, where people are mostly mildly dehydrated at home. There are going to be companies that try to make money off of that, called IV hydration therapy. And you can go to people's houses and start IVs and give them some fluids. And those fluids will have like nutrients and vitamins in them for adults. We don't do that for children. They need to go to the hospital. Okay. The worst type, severe dehydration. You need to know the differences between the 3 types of dehydration. Okay. I'm sorry, not the types. The 3 degrees of dehydration are extremely important. You need to know the differences. Even in everyday usage, if you want to work in the ER or anywhere, you should know that there are degrees of dehydration and how to start like correcting them. So we have weight loss, total body weight loss greater than 10%. This is very severe. Clinical manifestations, we're talking about cap refills greater than 4 seconds, tachycardia, tachypnea, hyperpnea. Anybody know the difference between tachypnea and hyperpnea? Hyperpnea is a type of breathing. What's the definition of hyperpnea? Are you going to take a stab at it? I ask because it shows up every once in a while. Like there's dyspnea, then there's apnea, and then there's tachypnea. Everybody knows tachypnea. Bradypnea. Everybody knows bradypnea, I hope. But this is hyperpnea. It is a type of breathing. It's a hyper breathing, but it's a difference between tachypnea and hyperpnea. And what is that? Anyone? Michael says excessive deep breathing. Michael is correct. Whose small respirations are different, Anastasia? But it is an increased rate of breathing, like tachypnea, but also an increased depth of breathing. The biggest difference is the depth. Tachypnea is rapid, shallow breathing. That's tachypnea. Hyperpnea is rapid, deep breathing. Too smalls. No, it's kind of close. Yeah, it's kind of like a Kussmaul breathing. But Kussmaul's is specific, don't mix it up here. Kussmaul's is specific to DKA, anesthesia. So if we had a DKA issue, you can absolutely use the word Kussmaul's. I don't want to mix that up here because this is specific for dehydration. It has nothing to do with the sugars. All right. But with severe dehydration, they can go into a hypovolemic shock. They are extremely thirsty. And you're like, well, why didn't the body is trying to compensate by making them thirsty, by making your patient thirsty, but they can't keep it down or they can't keep it in them. And that is, no matter how thirsty you are, we're going to have to do some interventions. They have no tears, they have sunken eyes, they have sunken fontanelles, they have oliguria or anuria. And do not, this is a star, please be really careful in any test question or any time out in the real world. If somebody orders potassium with IV fluids, because you have drawn labs and their potassium, well, no, we haven't drawn labs yet. Do not start IV fluids with potassium until kidney function is assessed. That is like a key point here, test taking strategy number 4,000, where potassium is usually the answer, and potassium is what we usually avoid if we don't have a kidney function test yet. Or if they ask you, like, you want to do potassium, which labs do you want to draw first? It has to be about kidney function. Got it? So this is a very good test strategy right here. Do not start IV fluids with potassium until kidney function is assessed. Key. Very key. All right, so let's fix these problems. When we're talking about fixing these issues, it's typically we start with oral rehydration therapy. We call it oral rehydration therapy. It is literally giving them something to drink. And it works best in mild and moderate cases of dehydration, right? Or if they can't keep it down, then we give parenteral fluid therapy. So IV fluid therapy, that's parenteral. And we can start with a bolus, with an isotonic solution. What are the only solutions we can give with a bolus? What are the only two that you should ever do with boluses? Right? 0.9 normal saline and one more, which we don't use as often. There's one other fluid we can give as a bolus. Nope, not D5. Nope. Not 4.5. We shouldn't give 0.45 normal saline or bolusing. It's lactated ringer. We can bolus with LR. We don't do it very often. Usually those are very emergency type situations or it's in surgery. We can do a bolus with LR. The most common bolus type and the only bolus type you guys should be doing is bolusing with 0.9 normal saline. Then there is it's weight-based. We can't just give boluses out willy-nilly. In an adult, we hold, how much blood does an adult hold? An adult human being, how many liters of blood do we have in them? Everybody know? We don't remember? An adult usually has 6 to 7 liters of blood. Well, I shouldn't say 6 to 7. Maybe 5 to 6 liters of blood. Look, it's liters of blood. It's a lot of blood. Okay? So giving an adult a bolus of 1 liter of 0.9 normal saline should make them feel better. It shouldn't tax their heart much. But in children, we can't just give a liter bolus. It'll kill them. Certainly depending on the size of the baby. It's as big as a baby. We could fluid overload them. So now we're talking about like trying to fix the dehydration. We've fluid overloaded, which is a big no-no. In reality, it's 20 milliliters per kilo is how we calculate boluses in children. It's a flat number. You don't need to memorize this. Unless you want to go into pediatrics, I would recommend you know this. So if we have a 10-kilo child, a 10-kilo child is 22 pounds in contact. It is a toddler, about. A 22-pound toddler, which is 10 kilos, 10 kilos, 10 times 20 is 200 milliliters for a bolus. 200. That's it. It's not, what's in a 1 liter bag? That's 1,000 milliliters. They get 200 milliliters. That's a full bolus. They can only get it 2 times if anybody, 0 to death. If they need a 3rd bolus and they're not improving, and your patient is not improving, they should be consulted to ICU. Like there should be an ICU consult happening because something is wrong. Somebody's going to end up overloading them. They need to go to the ICU. Why are they losing this fluid? Why is this fluid pressure not going up? There are problems. If we're leading toward a 3rd bolus and there is no actual improvement in your patient, they should start improving after the 1st bolus. All right. We don't do hypertonic dehydration, rapid fluid replacement. It is contraindicated because of the risk of cerebral edema. So hypertonic dehydration, rapid fluid replacement, that is giving a lot of fluids to somebody that's like their sodium's elevated. We got to be really careful because they could die from seizures. We got to be very careful on how fast we drop a sodium. Then we're going to give maintenance fluid as prescribed. We've done the maintenance fluid calculations. Again, it is weight-based. There's a whole thing to it. So if my toddler who got a 200 milliliter, 10-kilo toddler who got a 200 milliliter bolus and the doctor now suddenly orders maintenance fluids, which would make sense. If I had to bolus them, I'm going to expect some fluids. Then what his maintenance fluids needs to run at is 40. No, it's not just 40. Hold on. 10 times 4 is 40. And 10 times 2 is 20. So 60. So he's going to run at 60 milliliters per hour as a maintenance fluid. Maintenance fluids for kids should be D5.45 or D5.9. Right? And again, star here, avoid potassium replacement until kidney function is verified. If they are severely dehydrated or moderately dehydrated, they could be in acute renal failure. We always want to make sure that the kidneys are working, that they have kicked back in to gear because circulation is back before giving something with potassium. There are instances where they're in acute renal failure from dehydration and their kidneys don't kick in until tomorrow. Then they start, processing. We can't give them potassium. That we should not be. You'll have a potassium problem because they can't get rid of it. Okay. Any questions so far? We have more about oral rehydration. I just talked about IV fluids. We're going to talk more about this IV oral rehydration in a minute. All right. if you want to work ER, I'm going to tell you that this is extremely important, these pieces, for testing and for real life, because in the ER, people always come in at first with a dehydration issue, that they can't keep stuff down. This is like one of the most common things that they come into the ER for. Nausea, vomiting, diarrhea, stomach problems. And knowing when and how to use fluids to fix people is extremely important as a nurse. Okay. All right, so rehydration orally. This is the least invasive, and so the most important way and most very much tested. All right, so when we talking about oral rehydration for mild dehydration, they're usually around 50 milliliters per kilo. You don't need to memorize this number, all right? Just know that we encourage fluids every maybe 2 to 3 hours, 4 to 6 hours, depends on the age of the kid, but we're encouraging to drink oral fluids. And in moderate dehydration, we might push more fluids on them, 100 milliliters per kilo, because when we don't need like the maintenance fluid calculation here, they're drinking it. They're going to be absorbed by the stomach. All right, they're going to be absorbed. It's not invasive. We don't have to worry about overloading them that quickly. It's not a lot of going on here. But the types of fluids is what also is important here. For oral rehydration therapy, we have oral rehydration or replacement solutions. We can't use on testing anywhere brand names. So we'll never use Pedialyte or electrolyte Pedialyte or Gatorade. Well, they'll never say that. They call it oral rehydration solutions. They have electrolytes in them. In pediatrics, our go-to is Pedialyte. We do not use Gatorade. Gatorade can be used for adults, but it's not my favorite. It has sugar. It has fake sugar in it. It has there's a lot of stuff in there. The sugar content alone can cause some problems, and the artificial sweetener problem can cause diarrhea. I hope you know that. And then further compound my problem with the child if given to children, because they already probably have diarrhea. Let's not make it worse. Okay. So Pedialyte is the way to go. We have bottles and bottles of Pedialyte at the hospital, these little 2-ounce bottles, and they're great. They're also flavorless. They're salty water. It's salt water. Well, I call it salty water. It has sodium. It has electrolytes in it. For infants, we do the Pedialyte in little bottles, and we start off with that. If they can keep it down for an hour, then we give them more Pedialyte until they're well rehydrated. In children, we also give Pedialyte until they can hold it down, usually by the teaspoon. We don't recommend chugging it. And then they're going to resume a regular diet as soon as possible. For infants, we're trying to resume a regular diet, as in their breast milk or formula, as soon as possible. And I'll tell you a trick. In testing, they'll never ask you this. They'll just say, like, oral rehydration solutions. This is one of the choices you have. In real life, though, we'll start with the Pedialyte. And if they can hold it down, then we start like half-halfing the formula and and the Pedialyte, because I already told you we don't dilute formula with water. It's dangerous. It can cause water intoxication. But when we're talking about this rehydration therapy, there's electrolytes in Pedialyte, so we mix half Pedialyte, half formula, because the formula can sometimes get real thick, and like it's just this. If you've ever poured it, it's like very thick milk, unless it's made by powder. If it's made by powder, it's thinner. But at the hospital, we have bottles of pre-made formula, so it's much thicker. And so we'll like mix the two together. We can also recommend to moms to pump their breast milk, and then we'll mix some Pedialyte in it until the baby can like hold it down. Then we just, after, if they can stop vomiting, then they can just go straight back to straight up formula or straight up breast milk. That's real life solutions here, okay? On testing purposes, we're going to give Pedialyte, i.e. oral rehydration solutions. Any questions on this at all? I hope it's not complicated. Anyone? Questions? No? Not crazy? Thoughts here? Okay. Cool. All right. What time? Oh, it's time for a break. All right, let's take a 10-minute break while I set up for the next piece. I'm not going to go into this. Me too. Let's take a 10-minute break. So we'll be back at 10:25. And Haneen, I did see your message. Go into Core. I sent you the clinical learning contract through Core. Go look at it. There's directions at the top of it, so you just fill in your section, upload your doctor's note, either to that one if you can remember to do it in there, or just do both. And you're going to upload it to Canvas in week 8 supporting documents, if that helps. But it's in there. So once you fill your part out in Core Elms for the clinical learning contract, then just submit it and I'll go to the next person. Okay. All right. Back at 10:50. Not 10:50, 10:25. I asked. So the clinical schedule said that you register this week, so the clinical schedule comes out next week, I think. That's what I was told. You think that I would know because I do clinicals, but I actually don't know. I get told after you if I have to do clinical or not. Okay. I hope that helped. All right, let's get into some meat of GIGU. The meat of things. And we're going to do some of these, and then we're going to start talking about these 4. If we can get that far. We'll see. Where's my button? Okay, so for this week, this is one of we're going to talk about these first 4, our major, well, you need to know all of these. But they're very specific now. Okay, in general, this week is the care of the dehydrated child, which we went through in the first part. Now we're talking about the details, like what causes them to be, what possible problems could they have if they're, dehydrated and stuff like that. So these are specific diseases, the specific ones. We're going to start with the first one, which is Hirschsprung's disease, aka aganglionic megacolon. If you can remember aganglionic megacolon, and that is Hirschsprung's, then you know what's wrong with them. There are 4 total diseases that I talk about in this session that have a particular problem. In cystic fibrosis, the major problem with cystic fibrosis is that they don't have, I'm so sorry. One of the first diagnostic tools that we have to diagnose cystic fibrosis, what I should say, is that they do not have a meconium stool in the first 24 hours. All right, because in cystic fibrosis, as a review, they have thick mucus and they can't poop that out. And so a suspicious thing when a baby can't poop for the first 24 to 48 hours, lack of meconium stool here. Cystic fibrosis is on my list. This is the second disease that's on my list when a baby does not poop or have a meconium stool within the first 24 to 48 hours. And that's Hirschsprung. And the pictures describe why. It's aganglionic megacolon. So here are the ganglions. These are the nerves right here. And it should innervate all the way to the little rectum, the little bum hole. And it does not. So it doesn't have the intestine constrict. All right. Musculature, it doesn't work. So here is what Hirschsprung's looks like. This is normal. This is Hirschsprung's, the absence of ganglionic cells, aganglionic. And the colon is enlarged, megacolon. And they have this shrunken rectum. So how do we diagnose this? Baby doesn't poop within the first 24, 48 hours. This is congenital. They're born with this. And how do we fix it? We fix it by removing the offending piece. So they will go to surgery, and this will be removed wherever up to a certain point, not all of it. And up to this point here, it'll be removed. The little rectum will stay because there's still muscle there. They're going to have a temporary colostomy. It's temporary until this gets stronger and the baby gets bigger, and then it will be reattached. All right, they'll reattach. They have removed the part with no ganglionic cells, and they're going to reattach up to the point where there are ganglionic cells, and they're going to repair it. and they're going to reattach it to the end of the rectum. All right. And everybody's going to go on with their lives. So what is important here? Number one, Hirschsprung's is agangliotic megacolon. Number two, lack of meconium stool within the first 24 to 48 hours. Number three, intervention-wise, surgery and a temporary colostomy. And then it will be put back together. It is congenital and a newborn problem. That's all you need to know about Hirschsprung's. Okay, moving on to the second one. Oh, maybe we'll get to the other four. Now, write a small list on the side. The four problems of lack of meconium stool. Number one, no meconium stool is cystic fibrosis. That was one of our first ones. Second one was Hirschsprung's. All right, this one is not one, but I'm just reviewing. There are two more that we're going to learn about. One more today, and then one more next week, I do believe, in endocrine. Okay, so intussusception. Oh, I did mention this previously. I mentioned this before. I think we were talking about rotavirus. And I mentioned intussusception. And guess what? Now we need to know it. Intussusception is when the intestines telescope in on itself like this, right here. And it causes a bowel blockage. Now, what we have to know, I mean, just looking at it, this is intussusception right here and in the intestines. What the clinical manifestations are is bloody mucus stools that are bright red, and I put strawberry jam, and I will, no joke, will tell you, it looks like strawberry jam. It is bright red, it's mucusy consistency. You smear strawberry jam into a diaper, it's what it looks like when a baby has intussusception. How do other clinical manifestations, I should fix that part. Clinical manifestations, not just bloody stools, is a colicky abdominal pain. They, other clinical manifestation on palpation of the abdomen, it will have a sausage-shaped mass. Now, palpation isn't like the end all. You can feel a sausage-shaped mass, but that can also be mistaken for constipation. So how do we for sure, as a diagnostic, know that it's intussusception versus constipation? Because a constipation can give some bloody stools, or if they poop. And the only really good way of doing this is through ultrasound. So our diagnostic tool for intussusception is ultrasound, but it's also the cure if caught early, and usually they are. So we can do a barium or air enema with ultrasound, and while this is happening, the child, infant, toddler will attempt to poop because they're getting an enema, and the pooping, the heaviness of the barium or the air actually diffuses into this part, and it unblocks it. It will actually stretch the intestines back out, and problem solved. Okay, the only time this can get worse is if this bowel is necrotic, it's been too long, and we need to go to surgery to remove the bowel, necrotic bowel, and then they'll probably have, well, they'll probably have a temporary colostomy, and then it'll be reattached here. And it'll never happen again because that offending section is gone. It doesn't happen again. These babies, if we can get to them soon enough and give them their barium or air enema with ultrasound, and you can watch on ultrasound it being pulled back apart, it's great. It's a diagnostic tool and a cure, like the repair, the intervention to repair it, fix it. It shouldn't happen again. Intussusception is one and done. There are very rare occasions that it could happen again, but it's very rare. they have an increased risk for intussusception because of the rotavirus vaccine. Because of the diarrhea and the dehydration over catching intussusception, which is really rare. How many times have I ever seen So I worked in the OBS unit for like 3 years. I've only ever seen intussusception maybe like a handful of times. And even then, of the handful of times, they've all were fixed with an air enema. If the first time it didn't work, then they additionally add a barium enema. Like they'll get a second ultrasound and they'll get a barium enema, and that usually just solves the problem. Only one time was it a repeater who's has intussusception a couple of times, and it would resolve on its own on the ultrasound with or without the enema, but he would have colicky pain. Eventually, he went to outpatient GI and they removed that section, so it never became a problem again. But I have not ever seen it where they had a bowel resection. Maybe they don't go to the OBS unit. Those go from ER to surgery anyways, straight to surgery. So I usually don't see those. But very, very, very uncommon problem. And so getting the rotavirus vaccine is more important than worrying about intussusception, which is a highly solvable problem. Okay. Any questions? Oh, let me go back one. Any questions on intussusception or Hirschsprung's? These are very ped specific. I mean, intussusception can happen in adults. Don't get me wrong. It can. Very, very rarely. Very rarely. Much more common in children, but even there, it's a very uncommon thing. Okay. All right. Pyloric stenosis is specific to pediatrics, extremely specific. Okay, so pyloric stenosis, if you look on this picture here, is what it sounds like. Stenosis is a thickening of an area, kind of like, aortic stenosis or there's other stenosing. But for children, a pyloric stenosis, here's the pylorus right here. And here is the pyloric stenosis, the thickening of the stomach entrance into the intestines. So you can already see the problem. Clinical manifestations. Number 1, it only happens at the age between 4 to 8 weeks. Peak incidence, 6 to 8 weeks. All right, this is when we catch it. It'll start stenosing around 4 weeks, but by 8 weeks, it'll close off completely. And then they're in the ER and we have a problem. Okay, so number 1, only ever happens. It does not happen in adulthood. It never happens anywhere else or any other time. It only happens at the age between 4 to 8 weeks. It is rare, but there is some familial line to this. It's a congenital issue. It's a newborn. Well, not newborn, I should say. It's a congenital issue. There are some family histories involved in this. If there's like a family history of pyloric stenosis, there's a higher incidence of pyloric stenosis, but it can happen to any baby. All right, it's random. There's no etiology. None. Clinical manifestations. Projectile vomiting. They will vomit and it will go across the room, because just think about it as in a physiologic way. It physically, that if this is closing off and they have a stomach full of formula or breast milk, their tummy is full, they are hungry. They're very hungry because they aren't getting the nutrients that they need. So it goes into the stomach and it has nowhere to go, and it's churning. These babies will vomit, and it will shoot the formula or breast milk across the room. It is true projectile vomiting. It goes 3 feet. I've seen it shoot 3 to 4 feet out of this baby. Normal spit up, not this at all. All right. They're hungry. They cannot get food. So their stomach here, I should put this in here. They have a hyperactive bowel sounds, and they have, what is it called? Oh my God. It's when their belly ripples because it's so hungry. What is it called? When their stomach ripples. Sorry, it is. Oh, there it is. I should put this in here. Hold on. Oh, all right. They also have visible peristalsis. Okay, so it's visible peristalsis. You can see their stomachs rippling under, like, you see the intestines, their stomach down here, you can see it like ripple because they're just so hungry, and it's so hyperactive right now, and they're so angry, they're dehydrated. They have a metabolic alkalosis. All right, that because of the constant vomiting that they have. But after surgery, it gets rebalanced. So we have to, as nurses, our job here is to fix that rehydration. So this is like one of the key babies that need oral rehydration therapy and IV fluids and surgery and all this. So they're going to go for bowel surgery. What's going to happen is that they're going to fix the stenosis. I'm not going to tell you how they fix it. It doesn't matter to us. Once it's fixed, it never happens again. Promise. And if another clinical manifestation, if you palpate their abdomen, right about here in their upper gastric, epigastric area, you can feel an olive-shaped mass. It feels like a little olive. Have I felt this? Maybe once. All right. But I've had plenty of babies with pyloric stenosis. It's not, maybe a handful of times again. It is not super rare, but it's relatively uncommon. What do we need to know? We can do an ultrasound. It'll show right up in an ultrasound instantaneously. Key gold standard diagnostic is ultrasound for this. And then key intervention is surgery to fix the pyloric stenosis. And then our job here is to fix the metabolic alkalosis and the hunger and the dehydration problem. Okay, so we usually introduce it back to them. It's like a refeeding. So we refeed them. That's all there is to it. It's not complicated. Promise. It's a very specific disease. 2 pediatrics. Any questions on pyloric stenosis? Another name is hypertrophic pyloric stenosis. I did have a baby that came in at 7 weeks. He was vomiting, but he wasn't projectile vomiting at the time. And the ER did the ultrasound, and it didn't show up as pyloric stenosis at the time. And we were going to discharge the mom from the OBS unit, saying it was like a gastrointestinal reflux, which is very, 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 very common. But mom's like, no, he's still vomiting. And I was like, all right, well, I mean, I was in charge. I didn't have the patient. What's nice about the OBS unit on the weekends, like we always have attendings, even at night. And so the attending was like, you know what, let's do another ultrasound. It was only been a day in the OBS unit. It was like, let's do another ultrasound. The baby did just like projectile vomit. It hit the other side of the crib. Like it went there. And so on the second ultrasound, there it was, pyloric stenosis. So immediately the child got surgery, got refed, everything was fine, went home like in a couple of days. Wasn't really a big deal. But thank goodness the mom was like, no, I just don't feel comfortable about it. And you just have to trust these mothers for the most part that they know their kid. It wasn't her first kid, it was like her third one, and it was very unusual for her. So it was fine. We caught it. That's all that matters. I mean, he would have come back in the next day and we would have seen it again. The baby was not in any danger whatsoever. That was the youngest I've ever seen. Usually we catch it at 8 weeks. Okay. We typically don't catch them so early because it just starts around 4 weeks, and it usually peak incidence is around 8 weeks when it totally closes off. That's basically about pyloric stenosis. When I mention like only these certain ages, I get it's only at that age. So pay attention when they're asking you a question that they're giving you this. Sometimes they'll say like this 6-week-old has projectile vomiting and has an olive-shaped mass, and they can't keep anything down, and they have like these clinical manifestations of dehydration, and they ask you like what is going on or what are your interventions. You're going to suspect pyloric stenosis or hypertrophic pyloric stenosis. That's your suspect here. Typically when they ask you questions, they're going to say more like, oh, this infant, and then you're like, oh, in general it's an infant. But if they're giving you specific weeks or very specific ages, then sometimes it's a clue also, is what I'm saying. Okay. Appendicitis. Appendicitis, it's a review. You should have learned about appendicitis in health assessment and learned about appendicitis in med-surg. Appendicitis is appendicitis. It is the same in children as it is in adults. So I just added these lovely pictures here. Here's an appendix right here, and it's infected. It is a little organ. It is originally an organ that hangs off of the end of this intestine. And why does it get infected is because they can have fecal matter go into an appendix and not escape the appendix, and it causes inflammation. Just like, so why we add it here in pediatrics is because it mimics a lot of the other problems, the other pain issues, or it mimics constipation. And they love to ask you questions on appendicitis. Now, you should be glad that they ask you questions on appendicitis because it should be relatively simple. They're going to go to surgery and they're going to get it removed. If it's burst, then we can't remove it yet. They're going to have to get some antibiotics, and we're going to have to wait to remove this thing. So what's important about appendicitis? Clinical manifestation, abdominal pain in very specific areas, right? In very specific quadrants. In children, like I said, it mimics constipation. Sometimes they're both constipated and have appendicitis. They go to surgery, they get triple antibiotics. There really isn't anything really specific to understand about kids and appendicitis. It's exactly the same as an adult. I really can't think of anything strange. There's no like pearls of wisdom. Just review appendicitis. And review like pre and post appendicitis surgery. I know they do questions on that. All right, so I left it there to remind you to go review this problem. All right, so now we have a new slide. We have gastroesophageal reflux. Now, reflux in adults is, acid. In children, it's not so acidic. It's more about physiologic reflux. So it is a physical problem. So what happens is that they're small, right? So they have a short, they're babies. They physically have a shorter esophagus. And they have a weak, like, esophageal sphincter. Which means they can't keep formula in their stomach very easily. Esophageal sphincter. Which okay, that's, I mean, it doesn't mean there are, okay, if, sorry, if they have true reflux, will have a pH testing. Okay, so like pH probe testing. But typically, it's too much food. So most commonly, gastroesophageal reflux in babies are typically and most commonly an overfeeding problem, where parents are making too much feeds and the baby's sucking it down. Now, people are like, well, if they're full, they'll stop eating. These are babies. Infants do not stop feeding. You literally have to take it out of their mouth. Now, why do babies with breastfeeding have less instances of reflux, of gastroesophageal reflux? We'll just call it reflux or GER. Because number one, breast milk is much easier to digest. Number two, they're held longer. The way they're positioned for breastfeeding actually promotes them to not have reflux. Formula-fed babies have an increased risk for reflux because they are actually put down sooner. Scientifically, evidence-based wise, they are put down sooner and they are fed a different way than breastfed babies. So there are different interventions for preventing reflux. Okay, so number one, we have to make sure that the parents aren't overfeeding. I literally, all the time, the parents are making too much formula. This is very, very, very common issue. They come to the ER with this baby and they're like, the baby's vomiting all the time. They're spitting up all the time. There's something wrong. And the first thing I'm going to ask is very kindly, how much are you feeding this baby? How much formula are you making? How are they feeding? If it's a formula-fed baby. If it's a breastfed baby, what's the diet? Sometimes it leads down the line toward, a dairy intolerance. I wouldn't say allergy because allergy is like anaphylactic where they have hives and stuff. And intolerance is when they just can't digest it well. They don't do well on certain kind of dairy. So if the mom's eating, like taking in dairy to make milk production better, which they can, like cow's milk, the baby can develop a like lactose intolerance or lactose, basically. And so we have to cut the dairy out, or we have to go do like a lactose-free, dairy-free formula, like a soy-based formula. But that's neither here nor there. That's if they have breastfeeding reflux issues. Typically, more commonly I'll see an overfeeding of the formula, or if it's like bottle fed breast milk babies, they also will suck it down too fast. So our recommendation typically is, stop and burp the baby after every couple of ounces to prevent reflux, number one. So we'll get into some interventions in a minute. Okay. So over So what happens is that if this baby has a consistent spitting up problem, if they're feeding 6 ounces, depending on the age of the baby, let me tell you, if they're feeding on the age, so if they're 4 months old and they're feeding 8 ounces at a time and they're spitting some of it up, then we have to reduce the amount of feeding, but give it to them more often. It also works for like 1 month olds and 2 month olds. Sometimes the parents, when you make formula or when you make a bottle, they make like 2 ounces. That's still sometimes too much in the beginning. Sometimes we're talking about an ounce at a time. You got to feed them every couple of hours. We have to remind parents not to overfeed the baby in hopes that the baby will sleep longer, because the baby will spit up on you, and now we have another problem. So sorry to say, if a baby comes in with a reflux issue, the first intervention is typically reducing the amount of feeds, but feeding them more often. And then you'll see the parents go, oh my God, I had to feed them like every 2 to 3 hours, 1 to 2 hours, 3 to 4 hours. And I'm like, yeah, you came in with a problem of spitting up. That means that if there's no other issues, I'm talking about all the other issues are crossed off. Okay. And it's down to a feeding issue. You're going to have to feed them more often and reduce the amount of feeds. And you have to burp more. Sorry, it's more work, but this is a baby. A baby can't do it on their own. They cannot regulate themselves. Babies and they're going to say, but they're hungry. Okay, but they're a baby. Of course they're hungry, but they're going to overfeed themselves. They're going to suck it down. They're going to suck it down until they can't suck anymore. And then they're going to spit up on you. So then you're going to be concerned. So let's solve the problem, and let's not let the baby decide how much they want to drink, and you decide how much the baby drink, because you're the parent. You're the adult in this situation here. Okay. So interventions this is like our first intervention. Other intervention is to it's called GERD precautions, and we can tilt head of bed by 10 degrees. And this is a very common one that we do at the hospital all the time. And in the hospital, we prevent overfeeding. So, I love feeding babies. I love feeding babies. It's my favorite thing to do. And so I will literally pull it out of their mouth. I don't care. I'm watching them feed. After a couple of ounces, I don't care how big your baby is, I will pull it out of their mouth, sit them up, burp them, and then start over again. And they'll just keep drinking. They don't care they got burped. I mean, they might be a little bit mad, but if they're still hungry, give them a second. Give them a second for their brains to register that they're full or not, okay? A good eater will eat the whole thing, no matter what. So I hope this totally makes more sense now. And that's reflux. If they truly have, it's very rare for them to have a true reflux problem. And we'll do a pH probe on those particular babies. And they'll come to the hospital, we'll do a pH probe. But 99% of the time, it's an overfeeding problem. All right. That's reflux. And in infants, it's a physiologic reflux. Okay. Enuresis. What do you guys remember about enuresis? What does this mean? Can adults have enuresis? Or what is adult enuresis? And then we'll talk about the differences. Enuresis, anybody? I hope nobody has it. Kind of close. Yes. So enuresis in adults, like nocturnal enuresis, I hear that it's when they need to get up and go to the bathroom, or they can't control it, like they need a diaper in adults. But we have a difference between adult and childhood enuresis. There are two kinds. We have two issues with enuresis here. They never were potty trained. Or we're regressing. This is about the best way of doing this. So that's one kind of enuresis we have as an issue in pediatrics, that they aren't potty trained or never got to truly potty train, and we have enuresis. And this is past potty training age, or they're regressed, or there's like a neurologic issue. Then we have enuresis. Our others, that's one kind of enuresis. A second, well, I shouldn't say a second type. A third type is nocturnal. So these kids have daytime potty training down. Are but still wets the bed at night. So questions along this